to get up in front of a room of even as beautiful and caring as people as you are and talk about your experience of living well with cancer. So we really appreciate what TJ had to share, and her main message really that patients' voices do matter and that everyone in this room has a role to play to ensuring that we listen to patients and that we drive the change that's needed. So thank you, Tenielle. As Tenielle mentioned, she's receiving treatment through the Chris O'Brien Lifehouse, and Associate Professor Judith Lacey is the Head of Supportive Care and Integrative Oncology. And she's worked in palliative and supportive care for 25 years and is committed to improving outcomes and quality of life. And you heard from TJ talking about how her quality of life has improved, her physical health, her mental health, by having the opportunity to go to the facilities that Judith Lacey runs. She's a leader in integrative oncology and supportive care, and we're delighted to welcome her to CanForum. Please welcome Associate Professor Lacey.
So I'm quite short, and I actually can't see that from here, so I'm going to stand over if that's okay. And I'm going to be talking about this topic of supportive care, a nice to have or a must do, and what does the evidence say. But before I start, I just wanted to say how fantastic it is to be here and how honoured I am to be here. But particularly amazing to know that the reason that I'm here is because of the people that I serve and our department serves. And when you see Caitlin and Tenielle, you understand why I'm here, standing on my soapbox. And my slides aren't great because I'm very much an amateur PowerPoint builder, but I really like ChatGPT. So cancer care is changing. And cancer care is changing at a rapid rate, and we've been hearing about this, and we have new treatments. People are living longer with cancer. They're living longer with treatable but not curable cancer. The system that we have developed to support people with cancer needs to be transformed, and it needs to keep up with the changes that we're seeing in cancer care. It needs to be reviewed, it needs to be person-centred, it needs to be whole-person care, it needs to be patient-informed, patient-centric and personalised. And it's a multidisciplinary approach, as you've heard from Tenielle. And we need a trained workforce, and we need to invest in training a workforce that know what to do. It needs to be agile, it needs to be adaptive, it needs to be culturally sensitive, it needs to be all of that. People living with, and I love the young Archies, anyone from New South Wales has a great exhibition, but anyone who is working with people with rare cancers and less common cancers, usually working with a very diverse population, and they're usually quite young. And many of these people are actually living with treatable but not curable cancer. So with permission of some of my patients, I just took a snapshot of 10 of my patients that are more than just the statistics. We know the statistics. Almost 2 million people by 2040 will be living with a cancer diagnosis. Many of those will be living with rare and less common cancers. But this population are living all with treatable but not curable cancers, either working or trying to get employment or not able to work because of their cancer. And their parents and their carers and their professionals. And my job is just to keep them living well and thriving, and it's all of our job, isn't it? To keep people living well and thriving. And so it's personal. So what do we do in supportive cancer care when it comes to keeping people living well and thriving? Well, the first thing is we recognise what the problem is, and we recognise who we need to treat. And with this increasing chronicity of side effects from treatments and people on multiple lines of treatment, we need to have strategies and tools to manage these toxicities in a proactive manner. With this growing population of people living with treatable but not curable cancers, many of them are on multiple lines of treatment and novel therapies with novel toxicities. We need to understand what these novel toxicities are and the effect of accumulative toxicities. Look, I look after Caitlin, 14 lines of treatment. There are accumulations of toxicities. And so these can significantly impact on somebody's quality of life. But the goals of care are also changing, and patients' expectations are changing. And so People are looking for how to stay well on treatment, how to reduce the toxicities of their treatment, and how to look outside of the box of what else they can do to thrive and live fully with a cancer diagnosis, and modify and introduce lifestyle changes and reduce polypharmacy, because we don't want people living longer on morphine and benzodiazepines, do we? If the minimum that we provide is supportive cancer care across the continuum, I'm playing around with this, and I've been very honoured to be working with Rare Cancer Australia on the optimal care pathway. The acute toxicities of all these treatments are usually managed by the acute cancer team. We've sort of got that right, but what about the subacute and the chronic toxicities? Fatigue, neuropathy, mucositis, the immunotherapy-related toxicities, fear of recurrence, sexual dysfunction, lymphedema, all the long-term treatment-related toxicities. We need a workforce to manage these toxicities, and we need to know how best to support people who are living with cancer. And so over the years, a number of organisations have developed, and there are a number of definitions of different treatments. So our department is Integrative Oncology and Supportive Care. Ideally, it should be called Supportive Oncology. But there are two main institutions that are really leading the science and the evidence behind developing integrative oncology, supportive care and survivorship. And they are MASC, the Multinational Association of Supportive Cancer Care, and the Society of Integrative Oncology. Dorothy Keefe, our head of Cancer Australia, coined the phrase when she was president of MASC that it's supportive care makes excellent cancer care possible. And now these two organisations are working together to make sure that supportive care is available to make cancer care possible. And what integrative oncology adds is the evidence-informed and evidence-based complementary therapies, but also empowering people to be active participants in their own care. And you've heard from Tenielle how exercise makes a difference. She's an active participant in staying well. And if I jump back on my soapbox, I will say that every person from the time of diagnosis should be assessed for their supportive care and integrate their supportive care needs, and that should happen from diagnosis, during treatment, through survivorship and end of life. But God, it is so not linear. It really isn't linear. Just like life isn't linear, living with a rare and less common cancer, you can be well for a while and then your disease comes back. And you need to adapt the way you are being. You need to revisit what your symptoms are and how best to manage your well-being and get back on track. And so that's the role of supportive cancer care. So we need to develop systems, and we need to have goals. And so as we've developed a service, we developed an approach to care and survivorship for people living well with and keeping them thriving with and beyond cancer. And so if you look at those circles in my super-duper graphic of the three main goals. The first, I think, is the most important and the essential one, which is to ensure the best quality of life for patients, people, independent of their prognosis or stage of disease. And we've heard from Tracy O'Brien about the importance of patient-reported outcome measures, and we've embedded patient-reported outcome measures for the past 10 years into our supportive oncology space, and we now have EPROMs, electronic patient-recorded outcome measures, embedded into care before every consultation with people from our service. And that helps us develop proactive assessments and care plans. But we also need to be innovative. So one thing is to have a system and the other is to have innovative solutions. And that's where integrative oncology fits beautifully into supportive cancer care, where research and embedding research into supportive cancer care is essential, where AI will probably play a role to build predictive models of care, and where implementing guidelines comes into play. And we need to measure the outcomes and improve the outcomes, not just for the patients that we see in our very fortunate space, but for every person in Australia living with a rare or less common cancer. So we need to build systems that can be replicated elsewhere around Australia. None of this is funded. None of this is funded by the healthcare system except for at the end of life. And, acute oncology, you get 5 exercise sessions with Medicare a year. But no, you don't get 5. You get 5 allied health sessions a year. It's not enough. So what do we need to do to prove the value of what we do? And I love this piece from Rare Cancers Australia report from 2022 about how do we value what matters that's all been cut off to people living with cancer, and this concept of the social return on investment in this Counting the Costs report. And if you haven't read it, it's really worthwhile reading. And it's all about this, in essence, how do you keep people well? And the World Health Organization definition of wellness is this state of complete physical, mental and social well-being. It's not about the absence of disease. And so keeping a person in balance, keeping them at work, keeping them well enough to work, their spiritual, their emotional, their physical well-being. It's not about surviving, it's thriving. Very corny line, it's so important. We spend money on keeping people living 3 months more, but we don't spend money on keeping them thriving. And thriving means you can flourish and you have meaning in life. And we can do that, and we can empower people through lifestyle medicine and integrative oncology that uses these seven lifestyle practices. Eating well, moving well. We've got guidelines for all of this. Cancer Choices, you can go in there, get a lot of free information on how to integrate this into your life. Eating well, moving well, the importance of exercise, managing stress, sleeping well, creating a healing environment, sharing love and support and exploring what matters to the person, and all of this helps people to thrive. And if you can keep people thriving, like I think Tenielle and Caitlin do most of the time, except when things go upside down, you can keep people thriving. Now, there's a lot of science to this, and there's a lot of work, and you need a skilled workforce. So when I see a patient and when we train the teams and people in this space, there are complex factors that are involved from the medical side and the nurse specialist side to keep people well. You need to understand this person's cancer and the impact that cancer has on the person, and the impact of the patient's contributing factors have on that person and their well-being, whether it's their gut microbiome, inflammation, previous treatment, other comorbidities. You need to understand the treatments that they may be receiving in the future or they're receiving at the moment, and be symptom experts, symptom management experts, and understand those symptoms and recognise that symptoms don't occur in isolation but in clusters. Pain and fatigue, sleep disturbances, all cluster. And how do we use all the tools? If we expand our toolbox, how can we utilise each of those tools to build this comprehensive whole person approach to a person with cancer? And it's achievable. So a group of us got together through our global group, the Society for Integrative Oncology, and we wrote a guidance document. This is a global group, medical oncologists, radiation oncologists, all people working in integrative oncology, patient advocates, to say, what do you need in that comprehensive assessment, and how can you implement that, and what does the workforce need to look like, and how do you build this comprehensive program of care using patient-reported outcome measures to inform, to be open to reviewing it regularly, and work with a person to keep them as well as possible every day. We're really fortunate at Chris O'Brien Lifehouse, isn't it? It's a great photo of our department. And we're the most comprehensive integrative oncology service in Australia. And I'm just the doctor running being involved in leading a superb group of professionals in working together and to empower our patients and working with our patients to provide the best care possible. But we are also a recognised global centre of excellence in supportive cancer care, and we're one of 3 in Australia, the only one in New South Wales. And that means that we have to fulfil all of these core components to be a centre of excellence in supportive cancer care. And I believe that all of you can advocate for your hospital to be a centre of excellence in supportive cancer care. And I'm going to focus on these last few minutes on what it means to develop evidence-based practice and implement guidelines into care, because that is one of the criteria to be a centre of excellence in supportive cancer care. And MASC, the Multinational Association of Supportive Care, have developed brilliant guidelines available on their website to guide people providing that acute care for people receiving immunotherapy, as one example, pneumonitis, the liver function, the impact on acute hepatitis, endocrinopathies, all of these common side effects. And the value add to add in lifestyle medicine and integrative oncology is to say, well, what else can I do to keep you on immunotherapy and keep your symptoms well controlled and keep you thriving? And number one is exercise. We have the evidence to support exercise. Vitamin D plays an important part, the gut microbiome, a diverse diet, reducing the use of antibiotics, and, you know, the pros and cons of using cannabis for people on immunotherapy, which you can corner me and discuss at other times. And it's the gut microbiome which I'm particularly fascinated a bit, and I was partnered with some amazing researchers in this space to really explore this further in a chapter that will come out soon, because all our treatments can impact on the gut microbiome. The microbiome is something that you can modify with diet, exercise, stress management and other principles, and it's your gut and it's your gut health, and it may improve your response to treatment and your ability to cope with colitis and managing mucositis and other side effects. And the gut-brain axis is a whole field in itself. And finally, we have guidelines developed through ASCO, the American Society of Integrative Oncology, partnering with the Society of Integrative Oncology and developing a very robust process to say what's the level of evidence to make certain recommendations for non-pharmacological management of treatments for people living with cancer. And when you see a moderate level of evidence for exercise and mindfulness throughout the time, during and after treatment, you should have exercise programs in all of your cancer services. And so you need to implement, where the evidence is there, we need to be funding the implementation of personalised exercise programs for every person from the time of diagnosis into their cancer treatment to keep you living well and thriving. And similarly with anxiety and depression, mindfulness, we have actually high level of evidence to suggest that mindfulness-based interventions should be implemented for both anxiety and depression for people living with cancer. So we've taken that principle and said, well, how do you implement this into care? And thanks to some philanthropic support, we were able to set up, and superb leadership from a mindfulness practitioner whose PhD was in coping with uncertainty, a program targeting people living with treatable but not curable cancer, to run a mindfulness program for people to empower them and give them the skills to cope better with the uncertainty of living with treatable but not curable cancer. And Andrea Smith is in the room, who also joined us living with metastatic breast cancer. And most of these people are living with rare cancer. And they really found, and there's Tenielle, and found this experience really this beneficial 8 weeks after work, so they could go to work, come back from work, and then continue to develop their skills. And finally, we have built programs, and of course, these graphics are on a mind of their own, so if you look really quickly before they flick over, we've used our patient-reported outcome measures, we've used our evidence, and we've said, what if we can build a proactive approach to support people from the time of diagnosis? And, of course, we've got funding through breast cancer. Breast cancer is easier to fund programs, but we wanted to have a proof of concept of a proactive supportive care program for 20 weeks, exercising, a holistic, nurse-led consultation process to build a evidence-informed and evidence-based model of care, integrating psychotherapeutic interventions, exercise, education and integrative therapies into somebody's cancer care from the time of diagnosis. And these people came out stronger, they had less hospitalisations, but it was a pilot study. And we did a health economic evaluation. We know how much it costs, and it costs about the same as one visit to ED and 1 day, night in hospital would pay for the entire process. So how do we prove that this is helpful and we can get funding to run these packages of care for every person who is receiving treatment with a cancer. It's a dream. Is it a dream? I'm not quite sure. I'm dreaming, but I'm getting tired. And so finally, the next step is advocacy. Now, we've stood on these steps just out there somewhere and said you need a call for action because a growing population of people are living with cancer. How do we keep them living well? How do we build programs of care? How do we train a workforce? Haven't heard back yet. 3 years. Rare Cancer Australia do an amazing job. My colleagues in the NHS developed the UK Association of Supportive Care and are advocating that supportive oncology should be a specialty in itself, and they've developed and have approved a training program for that. And we've all got together and written papers together to advocate. And so we have a long to-do list, don't we? I believe firmly that supportive oncology should be funded and should be a part of comprehensive cancer care. Every person receiving a medication, a treatment that is going to keep them living longer needs to be kept living well, and we have enough science to implement programs that can keep them living well. It needs to be funded. We need to include the patient-recorded outcome measures should be standard of care. We need to develop pathways of care. We need to develop what is a sustainable model. We need to train a workforce in all of managing all these new toxicities. We need to be agile. We need to address the health disparities. It needs to be culturally sensitive. We need care navigators. And we need a consensus on what are the critical success factors so that we can move forward together. So thank you.